also delays discharge and confounded the benefits. We on purpose wanted to have time to discharge as the primary outcome because we knew and we were expecting an effect of apnea. So in a way, we designed the study to look at an important outcome that would not be biased by just the caffeine administration. It would have a clinical impact. I think, as Harshita mentioned, a younger gestational age cohort may have been a good idea. Those babies do have more apnea at later gestational ages. And the reason for not doing this is because we didn't want to confound with many other problems that extremely preterm babies have. And they're also included in many trials in the neonatal research network. So it's more difficult to do a study like this one late in the hospitalization when the babies would have been enrolled in other studies before, and according to our usual guidelines, are not eligible for a second trial at the same time within the same network. I'm not saying that there's never two trials at the same time, but we try to minimize the overlap between two trials. So, to summarize, it's a large trial. It's a practice that has been common. If you look at the paper and other studies that we reviewed here or reviewed elsewhere, it's a common practice. Maybe in some countries, 25 to 40% of the physicians prescribe it at some time. Doesn't mean that so many patients get the indication, but at least physicians, a substantial proportion of physicians use it. Caffeine has been used after an ALT event, not in the randomized control trial, but in 250 neonates who came back into the hospital. They were sent home on aminophylline, actually, and they did not have another episode, but it was not a randomized control trial. It was just observational study. So there's some evidence that the intervention works. I think a more selected population, for example, and in your environment, it may be possible that patients are ready on full feedings. I love the Paladin feeding. I've been trying to teach in the US how you all are experts feeding premature babies. So in that environment, it may be a possibility, especially after apnea prolongs hospitalization a lot. So I think it's a possible intervention in the future. I think more research is needed. Harshita mentioned the ICAF trial that was presented at PAS 2 years ago. And that one showed that it reduced lengths of stay, but that was not the primary outcome. That was an exploratory outcome. So I think more evidence is necessary. It would be helpful to make a more informed decision of patient care. So as was mentioned before by Ramesh, we're trying to individualize patient care. And I think this is the future of neonatology, in which we're going to try to individualize care to improve outcomes. Thanks for the opportunity to be here. Thank you for the invitation, Amit and Ramesh. Thank you. It's great to be here with you all today.
Thanks
Thank you, sir.
for wonderful comments. And over to Dr. Datta.
Yes, sir.
Yeah, thank you, Ramesh and Amit. And thank you, Wally, for giving that wonderful overview and putting everything in context. It was, I think, a fantastic manuscript, and also extremely well presented by Harshita, who covered almost every point that needed to be covered. Since I see still very few questions in the chat box, what I'm going to do is I'm just going to share a small PowerPoint presentation and take up a few more very nuanced teaching points from this presentation. With your permission, Amit, just for
Yes, sir.
2 or 3 minutes. Are you able to see my screen?
Yes, sir.
Yeah, so Harshita has already very nicely covered the issue of randomization. I'm not going to go over it all. There was just one little nuanced point that I want to bring up, because we in neonatology, face this more than in any other age group, and that is the issue of multiple births. What do you do with them? How do you randomize them? And there is an issue of multiple births being randomized separately, and that's because multiple births are not independent. I mean, twins, triplets, they share genetics, they share intrauterine environment, shared breast milk, shared maternal covariates. And as a result, outcomes among multiple births, that means among twins, triplets, or quadruplets, are likely to be more similar. And the word used is, clustered, than outcomes of unrelated infants. And what that does is it reduces the variability, in statistical jargon, that's called standard error, and falsely narrows 95% confidence intervals. So there are some solutions that have been proposed in the literature. The first is exclude multiple gestations altogether, but the trouble with that is that it reduces generalizability, and it becomes more difficult to achieve the sample size. The second is you treat the mother as the unit of randomization. That means multiple gestation infants all end up receiving the same allocation. But the problem with this is that that there is going to be clustering of outcomes. So the sample size then needs to be inflated in advance to account for this known clustering that's going to happen. The third is for twins, specifically randomize them 1:1 in the two arms. That means one twin goes to one arm, the other. Whenever you have a pair of twins, this at least doesn't takes care of the problem of clustering. But the problem that arises is with allocation concealment, because if you know that one twin is going to one arm, invariably the other twin has to go to the other arm. So allocation concealment becomes less unpredictable. And the third is individually randomized, which is what this study had followed. It is the simplest. A lot of people use it, but from a statistical point of view is the least desirable, especially if there are many multiple gestation babies. And then finally, in the analysis, if you do it, the analysis needs to account for that clustering. So in this study, we did have a number. The number of multiple gestation is not really mentioned in the table of baseline characteristics. Maybe Wally, you can throw some more light on this. They were individually randomized, and at least in the analysis, I was not able to find any mention for adjusting these multiple gestation. I'm not going to cover concealment of allocation blinding. They've already been very well covered by Harshita. Just a few points regarding the outcome. So this was what was mentioned about the primary outcome in the study. It said the primary analysis compared the number of days of hospitalization from randomization to discharge between the intervention and control groups with censoring at death, transfer, or 40 weeks post-menstrual age, whichever occurred first, using median regression with censoring, controlling for study, center, and gestational age group. And the outcomes presented are based on the median regression, but we assessed it at censoring in the median time to event survival analysis. Now, for beginners in the field, this may be quite daunting to understand what exactly this means. So I'm going to try and just unpack it for you. And it has a lot of nuggets of information and very interesting teaching points, and also shows how much the authors thought about all aspects of their trial before they actually planned it. So as we've been already told, the babies were born at 29 to 33 weeks. At PMA of 33 to 35 weeks, by the time by which one often considers stopping caffeine, they checked whether they met eligibility criteria for the trial. And in the intervention arm, they continued caffeine till hospital discharge. And they did not give caffeine, but they gave placebo till hospital discharge in the control arm. And then they give a further 28 days of caffeine at home after discharge in the intervention arm. And they continued placebo for another 28 days at home after discharge in the control arm. Now, it's important to remember that the primary outcome was a comparison of the duration of hospitalization after randomization in the extended caffeine arm versus the duration in the placebo arm. So it's important to appreciate that the primary outcome had nothing to do with the 28-day period of caffeine after discharge. So this 28-day period influenced only some of the secondary outcomes. So the primary outcome was influenced only by the decision to continue giving caffeine until hospital discharge. The authors were concerned that some patients may have died or got transferred out during the course of hospital stay, thus preventing the correct assessment of the duration of hospitalization after randomization. Because imagine if in the caffeine arm, you had more patients who were dying or getting transferred out, you would get the false impression that the duration of hospitalization was less in the caffeine arm. So this could have been a problem. And plus, the authors were worried that some infants may have stayed on for a very long length of time in the hospital beyond 48 weeks of postmenstrual age, and beyond that, the authors were really not interested in finding out the duration any further. So how did they handle this? The durations of hospital stay were likely to be skewed, so they were not able to compare the mean durations of hospital stay. They had to compare the medians. What they did was the primary outcome, that is the duration, was treated as the time to event. That means time to discharge after censoring. You saw that word censoring in the outcomes for death before discharge, transfer out, and crossing 48 weeks postmenstrual age. So, they handled it a bit like how you do survival analysis. So out here, there's a curve. So imagine everybody 100% are starting off being in the hospital, and every vertical drop out here against duration in days is an event. That means it's a discharge. Each vertical drop is a discharge till finally everybody gets discharged. And this is censored for death, transfer out, and crossing 48 weeks of postmenstrual age. What censored means is that those patients, they will contribute data till the point they die, get transferred out, or reach 48 weeks. And beyond that, they don't contribute any more information. So at least you don't lose all the information of somebody who has died or who's got transferred out. They still continue to provide the information to the trial until that event. And beyond that, they get so-called censored. So authors could have compared the median time to event, that means the time taken for 50% of the subjects in that group to be discharged. But there was another issue that troubled them. And that was that the duration could be influenced by confounders. Important confounders was the center, because practices, including discharge practices, may differ, and the gestation. Similarly here, it could be influenced by confounders. So putting all this together, they therefore decided to do what is called a multivariable median regression, which was mentioned in that primary analysis paragraph that I mentioned, adjusted for center and gestational age, and the duration censored for death, transfer out, and 48 weeks postmenstrual age. Median regression is very similar to multivariable linear regression, where the outcome is the mean of the outcome variable, whereas in median regression, it's the median. So basically, both of them end up looking like a formula like this. So at the end, the authors must have, the statistician in the study must have, derived a formula like this, which has the median duration is equal to a constant plus something multiplied by the group, plus something multiplied by the center, plus something multiplied by the gestational age group. So the group would be coded as 1 or 0. And ultimately, it is this coefficient which the group is being multiplied, which is effectively the difference in the median duration between the two groups. Because if other factors are held constant, with the caffeine, you get the caffeine duration by substituting group by 1. And with placebo, you get the placebo duration by substituting this group by 0. And then this beta 1 also has a confidence interval. That brings us to the primary outcome, which Harshita had shown. So as you can see here, this was the number of days of hospitalization, median, and the interquartile range in the extended caffeine and the placebo arm. Median was 18 here, 16.5 here. And these are the unadjusted median days, but censored for death, transfer, and postmenstrual age. Note that a crude unadjusted difference would have been 1.5 days, 18 minus 16.5. But when the regression analysis was done, the difference in the medians was actually 0. There was no difference. And that's because this 0 is after adjusting for center and gestational age. So it's different from the crude value. And the 95% confidence interval of the difference is from minus 1.7 days to plus 1.7 days. So this is the the unpacking of that whole primary outcome, which I wanted to share with you. We can take up a few questions which are in the chat box. So the first question was, I think, addressed to Wally Carlo. Was it easy to take consent, sir, especially explaining parents that the baby would either get or not get the drug by random chance? I think that's a generic question, true for all randomized control trials that involve drugs. But Wally, would you like to take that specifically for this trial? How easy was it to take consent in this trial?
Sorry. Yeah, so sorry, my microphone stopped working. So my speaker, sorry.
Okay.
Can you mention again the question?
Yeah. The question was, how easy was it to take consent in this trial? Were parents concerned that, by random chance, the baby would either get this drug for, prolonged duration or not get the drug?
So yeah, we got about 25% consent, and that's a little bit less than usually that we get. But I think the burden was high for these parents because they had to give a medication for a whole month. They also had to go home on a medication that was treating possibly treating apnea. And so most of the concerns were parents going through a study like this with their premature babies. It was not really that the parents objected to the study. They actually liked the study. Many times it was that they would rather go on caffeine home, which we have done in the past also. But in general, yes, it was difficult, but really it's because of the circumstances of having a sick baby in the neonatal ICU who is still having apnea. So it was not that that it was particularly upsetting for the parents or difficult for the parents to consent or not. Yeah.
Okay, there's another question from Amit Kumar. This is again addressed to Wally. Caffeine also leads to feed intolerance. So what is your view on the association of caffeine, probably prolonging the caffeine and possible feed intolerance? So could you address that?
So we look at that feeding intolerance. In our study, we report that as we agreed that the best way to assess real feeding intolerance would be being NPO for 24 hours. That was a criteria, pre-specified, agreed by all the centers. And that did not differ between the two groups. It was a trend for being better in the caffeine group. But the same observation was in the high-dose caffeine trial, in which also they did not find a difference in feeding intolerance. But that's a good point. And I think for the future, now we know that the best evidence now is that caffeine does not lead to feeding intolerance in these infants at this age.
Yeah, thank you for clarifying that. I think there are a few questions which are all related, and they were, what were the discharge criteria? I mean, were there standard discharge criteria that everybody had to follow across all centers, or was there some flexibility or leeway, left to individual centers?
So as a placebo-controlled trial, you don't have to have strict criteria that has to be followed. That's what we did is that each criteria. So the sites were free. They had to submit their plan for discharge. It had to be discussed by the whole group and not really approved, but understood why it was followed. Again, as a randomized controlled trial, that it was not a problem if some centers differ a little bit. For example, if you look at the data carefully, some patients were discharged soon after randomization, which really meant that they were not waiting the 5 days to 10 days that people said they usually wait when stopping caffeine. So in individual patients, there are other issues that they may decide to send the baby home earlier. So And just a few comments, Dr. Dura, because your review was excellent. Exactly the thought process that you couldn't be explained better. I think you explained it better than what I would have done. But it shows also the complexity in trying to do a really well-designed trial.
Yes.
It's very difficult to do, but it's a pragmatic trial. Interestingly, a few things that are really interesting is that when we did the study, infants who went home on caffeine usually went home on a monitor, but a monitor could have biased the parents or the clinicians. So we decided they had to go home without a monitor. So some parents objected to going on caffeine without a monitor, and that's one of the reasons for refusal.
Yeah, that was one of your exclusion criteria. Yeah.
Yep.
Yep.
Mhm.
Yep.
Yep.
Yeah. Okay. There are a few more questions. If we discharge the baby on caffeine, that's of course assuming that you are going to discharge, because this study doesn't really say that it changes the duration of hospitalization. For how long should we continue it, as parents may not be aware of mild apneic episodes, if any?
So we did 4 weeks, and that's based on how long it takes for this control of breathing to mature. It's still unclear. But for example, for research, we're doing sleep studies, and we show that at the time of discharge, there's still a lot of respiratory instability. Depending on the criteria that are used, most of the babies preemies at the time of discharge fail the sleep studies. And then we follow them at 3 months, corrected age, and almost all have resolved the problem. So, we try to balance the evidence of respiratory instability and not impose on the parents a very prolonged period of being on caffeine. We wanted to see if they could affect hospitalizations or emergency room visits. It did not. So I think it's a balance of trying to apply the evidence, but the balance of what could be done and what is acceptable for parents.
Yeah. The next question is, in a future trial on babies at a lower gestation, how can the confounding by feeding be taken care of? I'm not sure whether I've understood it correctly. And can a different primary outcome, like the number of apneas, be more fruitful than, I guess, in comparison to, say, duration of hospitalization? I guess that's what is meant.
Yeah, so the feeding issue, that's really context specific. In some places, they send babies home on cup feeding, or you probably send kids home, I assume, on Paladay feeding. I don't know, but in some places maybe. In many of the hospitals where we did the study, in most of the hospitals, they require full PO feeding. And that was the criteria for this study. But in other circumstances, it may differ if you send babies home on other methods of feeding. And you mentioned a second question, and I forgot.
Yeah, so the question was that would having a different primary outcome, like the number of apneas rather than the duration of hospitalization, be more fruitful? I guess, again, to take care of this issue that your duration of hospitalization may be dependent on other things like feeding and so on. Would changing the primary outcome be more fruitful?
So, no, when you're trying to come up with an outcome, ideally for a large trial like this, you want to come up with a very important outcome, So we thought 2 days of hospitalization, let's say for 28 days at home on caffeine, may be a good balance. But just having less apnea is not really an important outcome, important enough, when we know it's so strongly linked to the intervention. So one thing is that when you have an intervention like caffeine that is so strongly linked to desaturations or apnea, then your primary outcome may be best not to do it like that. That's okay for a pilot study, for a small single center trial, but it's really not ideal for a large multi-center trial where you're trying to change the needle, change recommendations of practice. In most centers, if you say, well, it didn't affect the hospitalization duration, but affected the oxygen saturation, you would not think that would be an important practice to change. So it's a balance of having an outcome that is related, but not directly related, immediately related, and is an outcome of major importance.
If I can take the liberty of paraphrasing what you said, Wally, I think what you're saying is that you all were looking for a patient-centric outcome or a parent-centric outcome, that it matters to everybody whether how long you stay in hospital, rather than having an outcome which was an intermediate towards that thing, the number of apneas that go towards, and there are many more things that affect hospitalization, which actually matters to patient, and you wanted to make a difference in that. Yeah.
That's correct, and this is similar to the earlier winning from the incubator that Sita Shankaran led in the network also. Yes, we could get the babies out of the incubator earlier, but that didn't affect the time from randomization to discharge. So this is a similar issue here also. I'm eager to do an intervention with oral feedings, and actually I'm eager to send some of our nurses to you so you can teach them Paladin feeding so they can go home on Paladin feeding.
Wally, the next question, I don't know whether you can see it on your screen. It's in the question and answer QA box. Is something that had troubled all of us when we read the paper, but I guess it was more of a typographical error, and maybe you can go back and see it. So what happens is in your paper, in the consort flow of the trial, it is mentioned that there were a large number of exclusions due to planned discontinuation of caffeine, having reached more than 120 ml per kg per day, being able to start medication less than 72 hours, being between 33 to 35 weeks of randomization. But really speaking, these are inclusion criteria, not exclusion criteria. And I was just wondering whether there's a typo somewhere in the paper. Maybe you intended to say not being planned to discontinue caffeine, not having reached to 120 ml per kg per day, and not being able to start medication in less than 72 hours. I think it's probably just slipped through the cracks somewhere. So maybe you could just...
So we have two lists. You're right. The first list is for inclusion criteria. So they did not meet inclusion criteria. That's the issue.
Probably I'm not there, because it does get a little confusing when you read it. Okay. So there's the next question is randomization was stratified for gestation and center. So what was the need for the regression adjusting for these two? And this is a methodological issue. And if it's okay with you, Wally, I'll just take this question up. So yes, this is a mandatory requirement. Even the consort and all regulatory authorities say that you have to adjust for variables for which you may have stratified. And the reason is that there is still some residual variance even after stratification that may remain in things for which you stratify. So stratification is not a panacea. It's not a magic thing that will ensure absolutely identical. And usually you stratify for the most important potential confounders. So therefore, it is important to adjust for these stratifying variables in the regression. You may opt to adjust for some more variables apart from the stratifying variables, but they all have to be pre-specified in the protocol. They're not something that you come up with after you've received your data. It should not be data-driven, your adjustment. It should be all pre-specified. They should be biologically plausible before the study had started. Okay. The next question.
You're right, and to highlight that, notice that we did not put statistical results without the adjustment. We put the raw data. Obviously, those cannot be adjusted. So we put the raw data, but only reported the statistical analysis of the adjusted. That's the
Yeah.
correct way to do it. Yeah.
Yes. Yeah. So that final right-hand column had only the adjusted analysis if you read the paper. Okay. Now, here is a question. Won't the death censoring reduce the duration of stay? If there are more deaths in one arm, it'll seem to perform better. Well, that's precisely the reason why you do censoring. Because if you were to just take the crude number of days before death and total it up without going through this survival analysis approach, you will arrive at a wrong conclusion that the arm in which there were more deaths actually had a mean shorter duration of hospital stay. So what the authors did was absolutely right. And although Wally, later on, I'll probably have a one-on-one discussion with you, whether it was correct to include death as a censoring variable, because it's truly speaking a competing variable for the outcome. I mean, when death occurs, you cannot have the outcome, which is, methodologically, there are some issues with that, but we'll discuss that later. I don't want to confuse people. So,
And it was only one death. It was
yeah,
after
so
discharge.
it doesn't really matter. Yeah.
It's in the caffeine group, but it was a car accident.
Okay. The next question is, does apnea resolution actually matter anymore if early apnea resolution doesn't shorten the hospital stay or reduce hospitalization? I think what the person is trying to say is that in the secondary outcomes, it has reduced apnea. So are we chasing a metric that no longer drives the primary outcome? So if your primary outcome has not been met, your secondary outcome, you have been able to show less apneas. So I think that's the sum and substance of the question. Should you still be recommending a longer duration of caffeine? I think that's what the person means. Yeah.
Yeah, I think at the present time, it should not be recommended based on this data and on these settings. In other settings, it may be different. I know we're doing some research, and in other settings, we have a high mortality rate in premature babies after they go home. And we're trying to sort it out and see if it's from apnea or something else. So I think it also depends. The discharge age at these babies is pretty late. In other settings, babies are discharged more like closer to 33, 34, 35 weeks. So.
Yeah, Wally, even in India, we tend to discharge babies much earlier than what you do in the US, taking a risk. We're actually taking a risk all the time when we're discharging that early. And we're always worried, what will happen, suppose they have an apnea at home. And I don't know. So that's why the implications may be different for a country like, and we don't have apnea monitors. Nobody's ever discharged on apnea monitors in India. So
yeah, we're doing a study now. We're doing a randomized control trial. So if you want to join us, or we're interested in testing this. Yep.
Okay. The next question is, in this trial, caffeine supplementation was associated with decreased weight gain, decreased apnea, but no difference in hospital stay. So putting all these three things together, what do you suggest, say, in a country like India, should we give oral caffeine or not after 33 to 35 weeks? So there was indeed a slightly less weight gain. That was.
Yes. So for discharge home, I cannot recommend it based on this data. In this type of population, it may be that other populations may benefit from it. Let's say babies who are on full feedings, that may be a difference. But based on this study, it cannot be recommended really. But it's important because the practice has been common in many places, in many countries. So I think the information is quite helpful.
Yeah, I think we are also running short of time. We're almost reaching 90 minutes. So I'll take up just one more question, maybe one or two. How did you ensure that the caffeine was actually taken at home? Well, in both the groups, the question out here is in the intervention group, but in both the groups, the parents must have been counseled that their babies actually did not need caffeine as per current practice, and 50% of the babies in the trial would anyway not get caffeine. So how did you ensure that they actually got the caffeine at home?
Yeah, so it's a pragmatic study. So we felt it would be better not to try to get serum levels. So that may be a limitation, but in the study that Eric Eichenwald presented, most patients took some medication. There was a significant difference, like 0. The level of caffeine was 0 in the group, and then normally in the other group. So, indicating that the overwhelming majority of the patients took the large number of doses. Obviously, in our study, not every parent gave all the doses, but there were instructions. If they miss a dose, that's okay. They can give the dose the next day. There were specific instructions on how to follow the protocol, even after they had missed 1 or 2 doses.
And I'll take up one last question, and that was, did you do a cost effectiveness analysis before you started the trial? What would have been the cost implications of prolonging caffeine versus the decreased cost of 2 days of hospital stay, which is, I think, an important question.
So that was considered for to do a study if it was effective. If it was not effective, obviously there's no point in doing a cost effectiveness analysis. Just would show cost only.
Okay. I think I'll end here. We've
I had one observation and a comment, sir. Many a times discharge in our place is not very well planned. At times, parents decide for discharge because of various reasons when the baby is still on caffeine or just caffeine has been stopped a day earlier only. So, in such a scenario, when babies are high risk, we tend to send them home on caffeine because that duration of 5 to 7 days of caffeine-free, apnea-free caffeine is not being there in the hospital. So, we have been doing this for a reasonable time. And so, how would you rate that practice of sending home in such a scenario a baby on caffeine?
So we have the same issues here. I've been sending home babies on caffeine or before aminophylline for years. And it depends many times on those circumstances that you mentioned. The mother wants to go home. We've been waiting days, and the baby's still having occasional episodes. And we don't think the baby is sick, so we goes home on caffeine. Yep. So we still do it after this study. We are not doing it routinely on all patients, but we do it selectively depending on specific circumstances. Yeah.
Yeah. So with that,
yes, sir.
With that, Amit, I'm sorry I have extended the time period. I know you wanted to finish it in an hour, but there were, so many questions. I didn't want to disappoint people who had asked so many very valid questions. So I hand over back to you to wrap up the proceedings.
Yes, sir. Thank you, sir. It was an excellent session, and it really enthused the group to have many more sessions after this inaugural session, and having it right from the horse's mouth, from the lead author was really great, and it enhanced our enriched our learning, and it gave a big insight into the making of the study and implementation. And people like Dr. Saurabh, Dr. Ramesh, who are deep into trials and studies, they would also have learned a lot from your insight and your expertise, I'm sure. So thank you, everybody, for being there, for giving extra time to us. It was planned to be a 60-minute session, but it has ended up being a 90-minute session. Still we have about 200 people on board, which tells us how engrossing this entire session was. Thank you, everybody.
Amit, maybe you could make an announcement of the neonatal research methodology workshop.
Yes.
On
so Dr.
31st.
Pratima, if you can show that we have a research methodology workshop coming over at end of August in Lady Hardinge Auditorium, and the flyers will be flown again. The date is 30 and 31st of August, over a Saturday and Sunday, with wonderful faculty who are experts in research methodology. They have been conducting this workshop for NNF for last many years, and we request all of you to join, let your PGs fellows join that workshop as well. And yes, and when is the next session, Dr. Saurabh? 28th of August?
28th of August, last Thursday, 8 p.m. Yeah.
By Hyderabad group, led by Dr. Veera Raghavan and his unit?
Yes, that's right.
So, and maybe we all will be there again. And thank you, sir. Thank you, Dr. Wali, especially for joining over from so far away, 7 sees a way, and we'll have you as a co-chairperson. Sir can be there in our journal club as well.
Thank you
Thank you,
so much.
everybody.
Thank you.
Thank you, sir. Bye
Okay,
bye.
thank you, everybody. Bye.
Thank you, Dr. Ramesh. Thank you, Harshada. Thank you, Dr. Bakhu.
Thank you very much.
Thanks to
Okay.
everyone.
Thank you, sir.
Thank you, Dr. Lalan.
Thank you. Thank you.
Dr. Somshekhar, if we can have this journal club as a an article in Journal of Neonatology, then it will be great.
I think
We can have the transcript, the questions, brief article
Questions.
followed by the questions and the answers which were there,
yes.
and a take-home message that will be of of good knowledge for the readers of your journal.
Sure. That would be great. Yeah.
Thank you, sir. Thank you, sir.
So,
Bye, sir.
bye, sir. Bye. Bye, Bakku, sir.
Bye.
Journal